And first of all, let me thank all of you for coming on Sunday morning to join us in the CME. And thank you so much for my introduction. And that banner is not incorrect. In fact, I am a general surgeon. And till 1986, I was a general surgeon, and then I became a neurosurgeon. So it's not incorrect. Maybe next time that
Yes.
we will make it correction. Before I start my lecture, I have some disclaimers. As Dr. Priyanka said, that I started neurosurgery in 1986. I passed out in 1990. And since 1990, I've been doing surgery for the brain stroke. Now, regarding that, I have a few disclaimers. Number one is the pendulum has swung. In the saying that what we saw in last century, it is very different in this century. Hypertension which is the biggest killer of humanity today by any disease, was hardly unheard of in last century. I mean, it was not heard of, or probably it was not detected. But this century, it has become really riding the chariot. It has become real major risk factors, both for the heart and the brain. But the disease that we're talking today of, that is a brain stroke, the disease which used to be for the old people in last century, it is now affecting younger crowd more and more in this century. Both the sexes, male as well as women, it is not exclusively now restricted to the male category. That is number one disclaimer. Number two is, we surgeons like to operate. We like to open people's brain. But after doing more than 1,000 surgeries on the brain stroke, what I've realized, the solution for the brain stroke is not inside the operation theatre. It is not. Every surgeon has got some skeleton in his cupboard. So much are the neurosurgeons. And then worst are the vascular neurosurgeons who have been doing this surgery for years together. They have the maximum skeleton in the cupboard. We are overflowing with the skeleton. What happens is that when we do the case nicely, we celebrate, and when the patient doesn't do well, we beat our chest. So the solution of brain stroke surgery is not in the operation theatre. That is number two. Third disclaimer is what was the era for neurosurgeon as far as vascular surgery or cerebral stroke is concerned in last century has been now taken over by people like Dr. Samir Kale, intervention neurosurgeons and neurologists. A little is coming to our way, and that our way is only about intracellular hematoma. So that is one good thing which has happened. A lot of things can be managed without surgery. But despite whatever science advances made in science and technology, let me tell you one thing: the brain stroke is a dark chapter in anybody's history. Absolutely, because when the brain stroke happens, whether it's ischemic stroke or the hemorrhagic stroke, the brain cells do not regenerate. It's a damage is permanent. What we are seeing, some improvement after surgery or without surgery in these patients is probably solely natural. I don't think that any of the intervention done by us, either a pharmacotherapy or surgery, is really helping the patient to improve further. Yes, surgery can prevent deaths, intervention can prevent further progression, there is no question about that. But the story of the brain stroke is very dark. That is one thing for sure. So with that, I will start my lecture. And I want to tell you I'm a neurosurgeon. I'm not a general surgeon. So that's what is written there. And when you talk of surgical role in brain stroke, I will restrict to intracellular hematoma, because otherwise the chapter is very big. It can go on for hours and hours. And in hematomas, I will focus more on hypertension, little bit on post-thrombolysis hemorrhages, people who are on dual antiplatelets, why do they bleed in the same, and hemorrhagic conversion brain infarct. I will not touch the trauma and vascular malformation, though aneurysm AVMC is my forte, but I'm not going to talk much on that. So let's start. Now, before we start, I want to give little glimpses about the anatomy of the brain. Now, the first slide that you see there on the top, it is about a single neuron that we have. We have about 100 billions of neurons in adult brain, 100 billions. And what happens that it has a nucleus and it has got a processes for the dendrites and axons, So there's a nucleus. And through this dendrites and axons, these cells are interconnected. Ultimately, we form a dense network of inside the brain, dense network, absolute dense network. If I collect this network end to end, the fibers in the brain will go on for somewhere 320,000 kilometers. So we are carrying nerve fibers which are about 320,000 kilometers length if I really check them end to end. And in the capillaries, if I see, these are the capillary network that we have. If I connect these capillaries end to end, it will go on for somewhere 700 kilometers. The reason to tell you this, that dense the network that we have inside the brain. Why am I telling you this? Now, brain stroke by definition is an event which is related to only the blood supply to the brain. Brain tumor causes neurological dysfunction, trauma causes problems, vascular disease causes problems, so many things causes problems. But by definition, anything to do with the blood supply, either supply or drainage of the brain blood vessel, causing neurological symptom is a brain stroke, and it's an acute process. Acute process means at this moment I'm completely normal, next moment I develop some problem, either speech deficit, I get hemiparesis, something of that kind. So the event has to be absolutely acute, and the event has to be related to either a blood supply or a venous drainage of the brain. That is classically a brain stroke. Now, why am I showing you this slide? The reason to show you this slide is, now I have drawn one circle here, this one here, Now what happens is that on the MRI, you might see a very, very small area of infarct or hemorrhage, but that is only small. MRI report says that it is 1 millimeter diameter, 2 millimeter diameter, but that 1 or 2 millimeter diameter infarct or hemorrhage, what it does, it will disconnect everything which passes through this area. Incoming fibers, outgoing fibers. So this small area in the internal capsular area, say for example, can produce tremendous devastation in the brain. Just a small area. We have three kinds of fibers here. One fiber is starting from point A, crosses the midline, go to the point B on the same location. Exactly two identical points are connected across the hemisphere. The second number of fibers is called arcuate or short oscillation fiber. They will start from point A and go to point B, just adjacent area. And third fiber, they will start from here, from the top of the head, goes through the internal capsule right down up to the foot. So they are pyramidal tracts. There are three kinds of fiber. Now, when this area gets involved in an infarct or hemorrhage, not only this long tract was suffered, but also the fibers that are going to the opposite side also get suffered. That's why a small, tiny piece of infarct or hemorrhage inside the brain can have devastating effect. He'll lose speech, he might lose power completely, he might be unconscious. And if that area is happening here, if that area is happening here in the brain stem, So can you see this red circle here? Yeah, this red circle. So there is an infarct into the brain stem. It will affect everything going down to the limbs. Eyeball movement, everything is affected. So tiny area can produce devastating problems for the patient. That's the reason I showed this slide. Second slide also is very important. This you have to understand little bit of physiology of the brain. When a child is born, the weight of the brain is about 10% of the body weight. So the baby is about 3.5 kg. The brain weighs about 350 grams. Understood? But as you grow older and older, say if you are a 70 kg person, your brain will weigh only 2% of your body weight. So maximally you can go to 1.4 to 1.5 kgs. So 70 kg person, the weight of the brain is only 2%. A newborn, weight of the brain is 10% of the body weight. Only 10%. And adult only 2%. But despite that, the 25% of the cardiac output, the blood supply from the heart goes entirely to the brain and only brain. So 20 to 25% blood supply goes to the brain because the brain requires so much blood flow. The brain is constantly active. That is number one. Number two, brain uses only oxygen and glucose for survival. only in oxygen glucose, and this oxygen glucose reaches brain through the blood supply. So for any reason, the blood supply to the brain is interrupted, brain will not get oxygen and glucose, and that is the time that you suffer with the brain stroke. That's why I'm showing this slide. Now, like your digital apparatus, they require you charge once your mobile, maybe 24 hours later you can recharge it because the battery lasts for 24 hours. Brain requires a constant charging, constant. You can't plug the brain and then come after some time and take your brain away and start using it. Brain will require a constant charging, and the charging will come only from the oxygen, and oxygen supply has to be constant. That is number 2. Number 3, if you see this cholesterol, now brain has its own factory to synthesize cholesterol. Brain does not depend upon the body cholesterol. Always remember that. Even if your body cholesterol is 500, that will not cross the blood-brain barrier to reach the brain. It will get deposited in your carotid arteries or vertebral arteries, but it will not cross. The high molecular cholesterol does not cross inside the brain. So brain has to have its own supply, has to have its own factory to produce the cholesterol. And why do you need the cholesterol for the brain? Because the signals that are produced inside the brain, they are like electrical signals. Just like your regular wires, copper wire, and the copper wire has an insulation of the cholesterol. And same thing here, the nerve fiber has to have myelin coverage to prevent the short circuiting of the signals. That's why cholesterol is must for the brain. But brain does not depend on cholesterol by the entire on the body. And lastly, this lymphatics. Brain is in a very exclusive organ, in the sense that like you have a venous system which drains the blood from the entire body towards the heart. Brain has other system. Brain does not share the normal venous system of the entire body. Brain has lymphatics, in the sense that it's a totally separate system. This will collect all the toxic matter, all the dead matters from the brain, and it drain it towards the heart. It's a completely different system. And this lymphatic system works best during night, during sleep. It's not necessary nowadays people sleep in the night, but people who sleep well, as Dr. Reshik was saying, unless and until you have a good sleep of 6 to 8 hours, the brain will not function properly, and that has become one of the most important risk factors for the brain stroke nowadays. So sleep is a must, and what sleep does, during the sleep, this lymphatic system gets activated. During day is completely is not working. It's not like our NAMC people that they work in the night and sleep in the they work in the day and sleep in the night. This lymphatic system will work only during sleeping period in the night time, not during the daytime. And that's why a sound sleep is most important, because if you don't sleep sound, these toxic products from the brain will not get drained, and that is what he calls a brain fog nowadays, the term which is coined nowadays, brain fog, where there is an error in decision making and all sorts of things happen. So sleep is most important. And lastly, the brain has no regeneration capacity. And once the brain cell die, it will not regrow. But what regrows, the new connections start coming in from to the dead area. And this is called the neuroplasticity, where brain can develop a new connections. So this is understanding of the brain stroke. So with that, one more thing that we have to notice. See, atherosclerosis, about 60 to 65% people with a brain stroke. Atherosclerosis is the cause for the brain stroke. Is the commonest cause for the brain stroke, atherosclerosis. No. In layman's word, what is atherosclerosis? With a deposit of lipid, fat in the intima, and that's why the caliber of the blood vessel goes down. A time comes when this caliber becomes critical and you present symptoms. So the atherosclerosis is a normal aging process. It's not the disease process. But people who have diabetes, who have hypertension, who are alcoholic, they're obese, hyperlipidemic, in all these people, this process is aggravated much sooner, at much younger age. And that's one of the reasons why you're seeing the high incidence of brain stroke in young people these days. And since the generalized process, it doesn't affect only the heart and the brain. It affects all the organs simultaneously, all the organs. Only the names are different, locations are different. When it affects the heart, you call it a heart attack. When it affects the brain, you call it a brain stroke. When it affects the kidneys, you call it a renal failure. When it affects the leg, you call it a gangrene. It's the same demon affecting all the organs in the body. It is not different one. It's not different. Many times, when the patient get admitted to us, with a heart attack, they soon develop brain stroke, or people get admitted with a brain stroke, they develop heart attack. So always say buy one get one free. So the incidence of this combo pack is very high. Brain and heart can get affected together in 17% of people. And look at this, brain, heart, peripheral artery, gangrene is high as 20 to 40% of people. So it is not a different disease. It's the same disease affecting different organs at different times of frame. Always remember that. So never blame the consultant on ICU. They say that we got our father admitted with a heart attack and he had a brain stroke. Something must have gone wrong. No, your father came with a problem. Your father had affected heart, affected brain, affected artery, everything. And we go to treat one disease and suddenly second disease interrupts. It comes on the surface. So it is not the doctor's fault. It is a problem that you have carried to the hospital. It is your fault. So, this is one thing that we never had in last century. People used to have just one risk factor, either hypertension or a diabetes, But nowadays, every patient who comes to us for a surgery, he have a combination. He has a diabetes, he has a blood pressure, he has a family history, he has a previous heart attack. So this particular combination increases stroke risk by many folds. It is not like, as I told you, last century, we never used to hear of hypertension, or probably it was not detected, maybe, But in my residency, I don't think that you have ever given a reference to physician or cardiologist who will come and check his blood pressure and control the blood pressure. Nowadays, every patient who comes in ICU gets a reference to the cardiologist to check the blood pressure. That high is the incidence of hypertension, and that's why the brain stroke is going up day by day. Now, let's talk about the blood pressure. There is something called the rule of 1/3. 1 in 3. What is that meaning? Every third person in our country has hypertension. Every third person. Yeah. What is the next third? That every third person does not know that he has hypertension. And the worst category is the third one. 1/3 patients who are on treatment for hypertension, they don't know whether that hypertension is coming under control with the given medicine or not. They take it for granted. I take this magic pill and my BP will control forever. There is no need to check again. I don't have to pay to the cardiologist again. There's one thing I don't know why people are afraid. If they want to go to a neurosurgeon, a cardiologist, they want to pay 3,000 rupees consulting fee, they get really jittery. You have been given prescribed one antihypertensive, अभी गोली चालू की अभी का जरूरत नहीं कुछ जाने का. Why pay 3,000 rupees unnecessarily? So this is a worst group, I can say. They are the people who generally, when they reach the hospital, the brain stroke, they have uncontrolled hypertension, uncontrolled. And remember, results of any intervention, whether thrombolysis, medical treatment or surgical, it depends upon what is your blood pressure during admission. The single most commonest denominator factor which will decide your prognosis after surgery, after intervention, after thrombolysis. There is only one solution for such people, that you have to undergo what is called the ABPM, ambulatory blood pressure monitoring. That is the only thing, non-invasive method, which will give you answer for people who have been diagnosed recently for the blood pressure, who are taking treatment for the blood pressure. Because this ABPM machine will go on for at least 24 to 48 hours. It will keep recording the blood pressure every half an hour. So in 48 hours, you will have 96 readings. And that's the only thing which will tell you whether you are hypertensive or not, or if you are hypertensive on treatment, whether that medicine is controlling your blood pressure or not. Remember this. That's the only thing. And please don't hesitate to ask for ABPM, because that's the only investigation which can keep your BP under check. Now, hypertension is a silent killer. There is no question, because it doesn't give you symptoms. It doesn't tell you that I have entered your body. It doesn't tell you anything, And remember, about 50 to 60% people who get admitted in the hospital intracerebral bleed, they have a hypertension diagnosed during the admission, or they are known hypertensive under treatment. 50 to 60% of people have a hypertension. In fact, about 40% of people hypertension, intracranial bleed can be the first presentation of hypertension. Heart attack can be first presentation of hypertension, diabetes. Similarly, brain stroke can be first presentation of hypertension. Remember, that deadly is a disease. Now, hypertension has a different target organs. Hypertension in the brain, it can cause infarct, as Dr. Reshik told you. Now, infarct and hemorrhage are two spectrum of the same disease. In infarct, the blood vessel gets blocked, like a heart attack, which is the commonest variety. And hemorrhage is something where the blood vessel ruptures. They're two different things, and the treatment is also different. You can't treat everybody with a brain stroke on this same principle. You have to diagnose first whether it's an infarct or with a hemorrhage, and the simplest investigation which can tell you the differentiation is a CT scan, which is available anywhere, which is takes about 2 minutes. If you want to do MRI, it takes 45 minutes. Patient brain infarct can be very irritable, restless, rowdy. They may not allow you to do the MRI. You may have to do sedation. CT scan is not like that. CT scan, it takes 2 minutes, available everywhere, cheaper, faster, and instantly you make a diagnosis. Because your entire treatment depends upon whether you have an infarct or brain hemorrhage. Remember that. Don't waste your time in doing an MRI. First get a CT scan done. If there is any doubt, if you want to investigate further, obviously you can go for an MRI. There is no question about that. Now, brain is not the only target organ. It can affect the carotid, hypertension, causing narrowing of the blood vessels. Then it can cause lacunar infarcts, so affecting the target or end vessels here. It can cause microbleed also. And in addition to brain, it can affect so many other organs, mainly heart, kidneys, and retina. Remember, retina examination is retina can diagnose about 1,000 conditions, medical conditions. Do you know that? Just one retinoscopy can diagnose that. And doing a retinoscopy can be a first marker that you are atherosclerotic, you are hypertensive, and you are likely to develop into a problem in the future. Maybe heart, maybe kidney, maybe brain. So don't ignore retina examination. Now, the commonest location of the brain hemorrhage, since we are talking about the brain hemorrhage now, we will not talk about the brain infarct, which has covered very well with Dr. Reshik. We are talking about the ICH, intracellular hematoma. They are the commonest site. They are called the lobar hematoma here, which is the commonest variety. Second is basal ganglia, then thalamic area. It can happen in the cerebellum, that is posterior fossa. It can happen in the brain stem. It can have only intravenous hemorrhage. So there are various presentation of intracellular hemorrhage. Commonest is this variety here, and then everything can happen, but in a reducing incidences. Nothing can really tell you what will cause where. Nothing, absolutely. But this is the commonest variety of intracellular hematoma. Now, at least in my unit, there is a practice. If anybody gets admitted with the intracellular hematoma, mainly because of hypertension, we always do intravenous study. Infarct, actually, when you do the CT scan for infarct, you should be doing carotid angiography that time itself. It will show us the major vessel blockage or not. Same thing for the brain intracellular hematoma. You must do intravenous study. Why? There is a reason for that. See, this is a patient with a small thalamic clot. This per se doesn't need any surgery. The clot is small, it is not causing mass effect, there is no midline shift, nothing, it doesn't need. But over a period of time, this patient might worsen. So we need to know which patient can worsen. One is the age, obviously. The people who are more than 60, they tend to worsen with a small hematoma. People who have unrestricted or uncontrolled blood pressure, they can worsen. People who are antiplatelets or dual antiplatelet, they can worsen. People who are heavily alcoholic, they can worsen. Now, obviously, people who have a coagulation disorder, they can worsen. There are the 5 varieties, common varieties. There are many other reasons for worsening or enlargement of the clot. But there is a way to detect it. If you do the intravenous CT scan in such people, you might see a small, can you see this small dot here? No, that's called the spot sign. What is the spot sign? When you do intravenous study of the dye study, that time the dye tend to exit through the blood vessel, through the rupture of the blood vessel, and this hematoma can enlarge over a period of time. So, whenever you see the spot sign on the CT angio or intravenous CT angiogram, in a case of intracellular hematoma, there are 10% chances that this patient will have enlargement of the clot after a few hours. In such people, every 6 hours we keep doing repeating the CT scan. People don't understand why are you repeating. We are repeating for this reason, because patient may worsen obviously neurologically with an enlargement clot, but that detection of enlargement may be detected very late. See, the patient admitted at 10 o'clock in the night, and you do this CT angio with the spot size seen. I mean, there has to be people who will keep observing this guy every hour, every half an hour. You might miss the diagnosis, you might miss the worsen of prognosis. But if you have this positive spot sign, you will be on the toes, because this is a likely guy who is going to worsen with the period of time. So we, as a routine, we do CT scan every 6 hours. If there is any progression or enlargement of the clot, we do take him for the surgery. That CT scan does not need a surgery. This does not need a surgery. This will need a surgery. Yeah, so this is one important thing. I am telling you something which is not, practiced everywhere. Now, again, as I told you, people who have uncontrolled hypertension or chronically hypertensive, this clot can enlarge in size. And this is a picture 2 hours after the onset when they came to us, and this is 6 hours after they reached to us. So this is because if you operate at this stage, he is likely to rebleed. So just wait for some time, because you anyway need time for the monitor to act, ventilator support, clearance and all those things. But always repeat a CT scan before you take him for surgery. Golden period, as Dr. Priyanka was saying, 29th October was a World Stroke Day, and the World Stroke Day theme was the World Stroke Day was the every minute counts. Now the reason every minute counts is this, that whether it's an infarct or whether it's a brain hemorrhage, every second that lapses, it will cause more and more death of the brain cells. Your burden of the death cell will go on increasing timelessly. So, and the time is the only thing which is in your hand, nothing else. Process happened, you can't do anything about it. Time is the only thing you can do something about it. So the treatment has to be immediate. Ideally, it is within 3 hours. It got extended to 4.5 hours. But I am of different opinion that I don't think we should be talking of 3 and 4.5 hours. We should be talking something like 60 minutes, door to needle time. If I get a symptoms, my treatment should be completed in 60 minutes. And this I have seen happening in other countries. It is not which is very difficult, because once the patient comes to us immediately, you do a CT scan. If it's a clot, treatment is different. If it's an infarct, treatment is different. Your treatment can be completed within first 60 minutes. That should be your aim, not 3 and 4.5 hours. What are the absolute indications for surgery? Now, absolute indication of surgery, lobar hematomas. Lobar means which are in the frontal lobe, which are a little superficial. They are the best clot to operate. Now, we can calculate the volume of the clot. We can have clot which are small, medium, the large clot. Anything below 20 ml, which need no attention, unless and until they are second into something. Sometimes, AVM can rupture, sometimes the aneurysm rupture, the clot can be very tiny, less than 20 ml. That's a different matter. We're talking about the primary clots. Primary means there is no reason, probably only hypertension reason. So if the clot size is less than 20 ml, you don't operate. If the clot size is more than 60 ml, like this, you will need a surgery. What is the purpose of surgery? That I will tell you later. But the clot which are between 20 and 40 or 60 ml, 20 and 40 ml, this clot need to be observed very, very carefully. Maybe by doing a contrast CT scan, maybe by keeping a close watch on a neurological progression, maybe by doing a repeat CT scan after some time. But if there is a progression in the clot, then obviously he is a candidate for surgery. But one thing is for sure, primary intracellular hematoma, which are less than 20 ml in diameter, volume, they do not need surgical intervention. Another strong intervention, surgical intervention, is the posterior fossa clot. Posterior fossa clot, because these clots are next to the brainstem. Any clot expansion will cause direct pressure on the brainstem and patient can die in a second. In really second, you have no time left for you to do anything about it. So posterior fossa clot needs to undergo surgery as a first priority. There you don't observe, you don't wait. This clot in less than 20 ml, you have an option to wait. If the clot is below 40 ml, you have option to wait for progression and then operate. But clot is more than 60 ml, they need a surgery. Fourth absolute indication for surgery is when there is a progressive worsening neurological problem. The patient has come to you conscious but is becoming drowsy and is developing deficit which were not there before. So there's the strongest indication for surgery. Okay. There are certain things where you can't do surgery. There is no point in doing surgery. For example, they are the clot which are dissected into the brainstem. The patient is gone. You can't do anything about it. Here, again, it has gone into dissected brainstem. Here, it is within the brainstem. You can't do anything about this. We have done some surgery where the clots were inside the brainstem, but they were secondary to cavernomas and stuff like that. There we have done surgery. But primary brainstem hemorrhage, when they are large, and if that is coupled with patient who is almost brain dead, there is no point in doing surgery. There is one more category where you can't do surgery, is this one. You see his brain is completely black, and this black brain is called angiographic brain death. Saying that the pressure inside the skull has gone up so high, even the blood is not able to enter inside the skull. So when you give the dye, because the blood is not entering the skull, your dye will not enter into the skull. That is called angiographic brain death. Here the patient is already brain dead. There is no point in doing any kind of decompression inside this. Plus, there are certain cases that we have seen post thrombolysis hemorrhages. They can be multiple, at various places post thrombolysis. There is no point in doing surgery in such cases because they are bad. And so there are certain things where you cannot offer surgery because there is no point in doing surgery. Now coming to post thrombolytic ICS, we were lucky in last century because thrombolysis was not so common. As far as the brain is concerned, they should do thrombolysis for the heart cases, but not for the brain so much. This is the thing which has come in this particular century. Thrombolysis is a very, very good procedure if the patient reaches to you early and he has a brain infarct. You can reverse the deficit completely and permanently. No question about that. But also with this rampant thrombolysis, we have seen certain complications of thrombolysis. There are various reasons which obviously I don't want to discuss it here. But we have seen the complication. But if you look at the incidence, about 10 to 40% people will have some complications, small bleeds, post thrombolysis, stuff like that. But of those, I think 2 to 7% will have significant bleed, which might require surgical intervention or decompression. 7% is not something small. Now, what are the key risk factors post thrombolysis ICH? One is older age, people who are more than 67 years old. Second thing, when they have a high glucose level, they are hyperglycemic when they reach the hospital. Third thing is they have uncontrolled hypertension when they reach the hospital. Fourth thing, when the larger area of the brain infarct is involved. Sometimes we see the complete medial artery occlusion causing hemispheric infarcts. So those are the patients who are more prone to get this hemorrhagic complication. People who have history of atrial fibrillation or previous stroke, they are prone to develop this problem. And people who are on double antiplatelet medicine already when they reach the hospital. So there are 6 to 7 risk factors. And second thing, as I said before also, that this has become really rampant at many places where there is no supervision, there is no ICU, and which has really is a cause of concern these days. And the treatment, if at all the patient gets referred to us, and if the person is suitable candidate for surgery, then we have to decide this. If there is a progressive worsening in the clinical symptoms, and or sudden worsening, these are cases where we do offer surgery, though the results are not really gratifying. Venous infarct, that sometimes one good thing of venous infarct is most of the patients do well. Most of them do well. They can go back to the normal life, just with double antiplatelet, this kind of therapy. But some patients do worsen. They do develop hemorrhagic complication, and they are large. They will need a surgery. So that is one of the surgical indication for hemorrhagic venous infarct. But remember, when we operate such people, we don't remove the clot. We don't touch the clot because this bleeding is intermixed with the normal brain. So when you try to remove the clot, you will also remove the normal brain. We just do decompression. We just remove the bone flap from here and let the brain get decompressed. And that's the only thing that we offer as far as venous hemorrhage, venous infarcts are concerned. The results are gratifying and they are very good. So there are multiple options for surgery. One is you can remove the clot surgically, either by doing open surgery or by using endoscope. And there are third method that we have used quite frequently in the past, that people who are not fit to undergo surgery for various medical reasons or uncontrolled hypertension, what we used to do, we used to do a small burrow, small burrow. I'll just show the slide. Suppose I want to remove this clot and he is not surgically fit. So what I can do a small burrow over here and we can put in a catheter and inject thrombolizing agent inside the clot because he is just not fit to undergo surgery. So what do? Clot needs removal, the guy is not fit for surgery, then we do minimal thing. We can, under local anesthesia, we can make a burrow, put in a catheter inside and inject one of the thrombolytic agent, and that drain will keep draining very gradually, and sometimes we have shown really wonderful results in some complete tumor clot removal and done very well, So there are a few examples of endoscopic clot removal. This is done by Dr. Anshu Varade. He is my colleague in Fortis Hospital, So we do we do very small craniotomy. This is a larger one for the decompression. And from here to the endoscope, we remove this clot. See this clot, and this is a post-op CT scan. They are the clot with the post-op CT scan. They are the clots pre-operative, they are the post-op CT scans. So extremely good results with our endoscopy. I don't do it, but Dr. Anshu Varade does it. Now, what's the prognosis? Many times we feel that I've done the surgery wonderfully, clot has come out completely, CT scan is very good, relatively have spent about 6-7 lakhs of rupees. But what is the ultimate prognosis depends upon, Many times I feel that when we operate for interstitial hematoma, we are producing the living bodies, because they have such a massive deficit which is unlikely to improve over a period of time, or if the improvement is there, it is going to be very minimal improvement, which is probably not useful for himself, forget about his family. So we are not very happy about surgery for the brain stroke, but we have to do that. So they are the people who can have better outcome after removal interstitial clot. People who are less than 60, people who have Glasgow coma scale is less than 8. That means they are better preserved neurologically. So if you operate on such patients, the results also are better. If the patient is brain dead, either you operate to produce brain dead patient, the relatives, or you don't operate because there is no chance, Because once you operate, if the patient is brain dead, and suppose you operate such cases, you are just producing another living meat. There is nothing more they can produce. It is not really useful to anybody. So one in the age less than 60, Glasgow coma scale less than 8, hematoma volume which is less than 60. That is what I was telling you. See, more than 60, when the clot is very big, the destruction is permanent. You can't reverse the destruction. But if the clot is less than 60, between 40 and 60, they are the best people where you can have a good surgical result. You are happy yourself. Lobar hematomas, which are on the surface, they have a better prognosis than the deeper hematomas, thalamic clot, basal ganglia. We do surgery, we are happy surgically, but results are not so very gratifying. And if you operate within 6 hours, always remember, sometimes, patients are cooked in the other hospital, they are sent to us after 2-3 days. This is just a surgical exercise, but as far as prognosis is concerned, surgically, they don't do well. And outcome, this again, mortality, those who undergo decompressive craniotomy mainly is 50%. 50%. It may not be, it is not related to your surgical outcome. It is related to your basic disease that you have, atherosclerosis. It is related to other complications which are associated with the neurological problem. Like patient might develop pneumonia, deep vein thrombosis, bed sore. That's the main reason for having a bad outcome. Functional independence is only in 25% of people. Only 25. That too with lots of aggressive physiotherapy after surgery. And as I said before, the outcomes are better with the surface hematoma and the deep hematoma. and outcomes are better with minimally invasive surgery rather than the larger craniotomy. This one surgery I hate to do, decompression. Now, you must have read the reports of the CT scan MRI, midline shift or 4 millimeter, 5 millimeter. What does it suggest? What does it mean, midline shift? Brain has got two halves, left and right half. When one brain shifts to other side, that shift is called the midline shift. Okay. Now, if you see this CT scan here, this is a midline here. This brain is infarcted and this brain is swollen, so it is shifted the whole thing to right side. This is a normal center of your brain. This should have been here, but now it is shifted by this much. That's a midline shift. And when the midline shift crosses 5 millimeter, that means you are endangering the brainstem. And that is why, when you read the report of the CT MRI midline shift, our residents keep shouting midline shift, midline shift. Oh, why are they shouting? They are shouting because the patient has to be taken immediately. That's the idea of calling midline shift. But we have done surgeries for decompression for hemispheric infarct. But believe me, apart from adding to my monthly check from Fortis, it is not really doing good to the patient. Because when the midline shift happens, when the brain is so much swollen, sometimes you find it difficult even to close the skin. That's swelling, because brain is like a toothpaste. Once you open the cover of the toothpaste and squeeze it, the whole toothpaste will come out. Right? So if the brain swelling is so much, the brain bursts on your face. In fact, sometimes it is very difficult even to close a scalp. That this patient do not survive. They don't do anything good to the patient. So the satisfaction is almost zero. In fact, your chance of going into depression are very high rather than being happy about it. So, and functional outcome after decompression craniotomy, mortality is about 50%. And if it's done in 6 hours, it can save life. That's all. Period. Nothing beyond that. It can save life. Person will improve naturally. It will take some time, maybe 6 months with regular physiotherapy and all those kind of things, neurorehabilitation. But surgery can save life provided it is done in early stage, even before the Glasgow Coma scale worsens. So that one thing has to be taken. But mortality of this thing is very high. Now coming to another surgical arena in our neurosurgeon, that in the past that we used to have this carotid stenosis, here, and we used to do carotid end arterectomy. But now with the intervention, people are stepping in. It is done less and less. But this we used to do very, very regularly in the past. And now this is one thing that I want to show you. One patient who had come here, you can see the thrombus here. Yeah, can you see the thrombus here? And this guy had a speech problem. He had hemiparesis, almost hemiplegic. And we did a carotid endarterectomy, and this guy improved, went home walking. He was from Karjat. So there was, surgeon had some role into this kind of thing. But nowadays, Dr. Kale is doing this stenting, so he has taken out from us, and actually we are very happy about it. And another area where we have some expertise in revascular surgery, and this also we used to do very frequently in the past, STMC bypass, and this is the area where M1 is blocked, and this is after bypass surgery. So this also we have done in the past. This one thing I want to tell you a little more detail. See, when you talk of involvement of the carotid vertebral arteries, it can involve the main carotid artery where you require angioplasty or end arterectomy. But there are certain areas where the disease is into the end arteries. Saying that arteries dividing into medium size and small size, smaller branches, and then end arteries. So what you see in the lacunar infarcts of end artery disease, even that can produce a brain stroke. And in that case, you have tried giving antiplatelets, dual antiplatelet. They will help the patient to a certain extent. But despite that, despite medicines, they keep getting transient ischemic attacks. So we have about 30-35 such cases. And in them, we have done the PET CT scan where we've shown hypoperfusion areas. We have done this procedure where we revascularize the brain using the temporal muscle in the dura. And after a year or so, we have repeated the PET CT scan, and you see the improvement in the blood flow on that side of the brain. When patient has improved, the TIA symptom either have disappeared or reduced in frequency. This we have done quite frequently, but getting such cases is very, very rare. Now coming to my area where aneurysm also can cause very severe hemorrhages. This is a severe form of brain hemorrhage, and we have done the angiography, showed a giant middle cerebral artery aneurysm, which required multiple clips to apply to obliterate. Multiple clips. This case was, this I done in Ruby Hall, Pune, and this patient was referred to the intervention guys, but they said that we cannot really coil this aneurysm because it was very wide mouth and it was expensive and they could not afford this. So it was referred to us for the surgery. We did the surgery. We acquired multiple clips. And after clipping this aneurysm, we always do what is called ICG study, indocyanine green study, and that study will show you whether the vessels are patent or not. You know, it will show you clearly the parent vessel is completely patent and aneurysm is taken off the circulation. So another area where we have an experience is about AVM, which also can cause brain hemorrhage. Now this one section I really want to cover: misdiagnosis. You know, misdiagnosis. It was saying that this is a CT scan. It shows brain hemorrhage. He was being treated for hypertension, and they keep treating him for hypertension. They were sent to us. We just got a CT angio done, and CT angio showed an aneurysm. So hypertension was not the cause of brain hemorrhage. It was the aneurysm which was cause of brain hemorrhage. We could have missed it completely. Another thing, you know, this CT scan. You can see the clot here. The intracerebral clot or hypertensive clots are never like this. They are one single blob of blood inside the CT scan. They are never bisected like that. You know, we did a DSA, we found the AVM, and we operated this patient. So there is another case where the diagnosis was missed. Third thing, this patient again had a acute and chronic subdural hematoma. Operated, you know, operated us only. But we removed it because patient was bad, so we removed the clot. But we did the study later on, MRI and MRI and DSA, and we found out that patient has an aneurysm, IC aneurysm, which had ruptured causing subdural hematoma. So subdural hematoma was a complication of aneurysmal rupture. So he need to be operated for an aneurysm. Another thing, again this was said that this hypertensive clot, something was missing here. We got the CT angio done, he showed an aneurysm. This patient we could not operate because when he came to us, he was brain dead. So, but we can miss the diagnosis in a patient. So, thank you so much for attending this, and I hope it was useful. Thank you.
Any questions?
Any questions?
Yeah, regarding in the cardiac, basically heart attack, we say that collateral circulation take care sometimes the patient improves much better. What about the cerebral circulation?
This is a very good,
cerebral thrombosis?
very good question you asked. There is something called the cerebrovascular reserve. Yeah? I'm talking atherosclerotic pathology inside the brain. I'm not talking embolic pathology. Atherosclerosis is occlusion always gradual, like a heart attack. You know? Gradually the blood cell go on constricting. So whenever there is a ischemia of any organs try to develop a collateral blood supply. It derives blood from other blood vessels. This is called as a collateral reserve. So in brain stroke, it is not only about surgery, remove the clot, but also it is important to know what is a cerebral vascular reserve. Because we do this surgery by STMC bypass, we do this EDAS procedure, we have to know what is the reserve. If the reserve is very poor, or when you do the angiography, you know, you have a left brain and right brain. So suppose you do left carotid angiography, you have to see how much blood really passing across the midline to going to the right side. So we see cross circulation. So one you see the cerebral blood reserve, second you see the cross circulation. Any of these two things are poor, chances of that patient developing brain infarcts are very high. And this is where this prophylactic surgery comes into the picture. If your reserve is very poor, if you have very poor vascular cross flow, yeah, these are the patients who should be subjected for the revascularization, and we have shown good results, very good results. But results will come only late, after a year or so, after they develop the collateral. See, in Moya also, they have a lot of collateral. And there are certain cases where you have done the STMCA bypass, You have provided a good circulation, but when you do that, the collateral supply which is already developed dies because now you have opened up the main pathway. And these people have developed deficit after successful STMC bypass surgery. It looks very nice on angiography. It is done very well, but patient is not doing well. Why it is not doing well? Because this collateral, your brain was actually living on the collateral, and now you have done STMC bypass. So collateral supply suddenly goes down.
Sir, I would like to ask, you just said sleep is good for drainage of lymphatics of brain.
No, come again.
Sleep
You
is,
said
sleep is good for
lymphatics of
drainage
the
of
brain.
Sleep.
Sleep is good for that. I would just like to know, in fact, can you just specify, there are people, in fact, who have total insomnia, people who have got different disturbed sleeps, people who do not get, people, in fact, who got lack of sleep, in fact, not 8 hours complete sleep or so. Which one of that is bad, sir? Nowadays, parents, in fact, even both parents are working, children keep them awake till 1, 2 or so, in fact. So, which one of that particular sleep, or just physical, you're lying in the bed, will that help? So, which one of that sleep is
Yeah,
bad?
I'll answer you. If Priyanka allows me, I can take a full lecture on sleep at this moment.
Yeah,
Just now. No, you have to understand one thing very clearly. Now, when a newborn is born, he sleeps for 18-20 hours a day. Yeah? He sleeps for 20 hours a day. As you becoming older and older, your sleep duration goes on decreasing. After 60, generally people sleep for 5 to 6 hours, but they do require at least 6 to 7 to 8 hours of sleep minimum. Your 1/3 life is supposed to spend in sleeping. Do you know this? 1/3 life. Because of 24 hours, you are supposed to sleep for 8 hours. So 1/3 life goes into sleep, which is most important thing. As I told you, this lymphatic system, the system which clears your toxic material from the brain, it works best during sleep. Works best. If you sleep less, this is going to go for a toss. And then this creates a lots of problems. As Dr. Reshik was saying, this sleep disturbances has become one of the independent risk factors in the brain stroke. That important is sleep. So if you can't sleep, there is something wrong with you. I mean, some practices you are doing which is not making you sleep. And most important is the use of digital media. नहीं नाता नहीं इसके लिए we keep watching your YouTube and Shahrukh and Salman Khan. No, that is wrong. See, there are certain things. You should avoid caffeine after 6 o'clock, tea after 6 o'clock, avoid any digital media after 8 o'clock. If you do that, and simple thing like, putting a blue light in your bedroom, probably will give you some good sleep. But that has to be associated with a regular meditation, some kind of physical exercise. Taking medicine across the counter is not the solution. It is not a treatment at all.
How far craniotomies serve the purpose in case of stroke?
Sorry?
In case of a patient with stroke, going for a craniotomy or conservative management, which one is a better option?
No, it depends on the indication. The single most reason for surgery is a gradual worsening the neurological status. Always remember that. I have consulted so many people, they had a clot inside the brain, but they were intact neurologically, and we have observed them over a period of time and they have done well. Because surgery is not going to reverse back your deficit, remember that.
Is there any golden period for craniotomies to be done post?
As early as possible. As early as possible. See, when the brain image occurs, it's like a bomb. Suppose the small bomb ruptures here, this part will get destroyed completely. This is not going to come back again. So, surgery is not going to reverse what is already lost.
Natural sleep and induced sleep by medicine.
I am a surgeon, but still I will answer you. No, natural sleep, always. Always.
Sir, you mentioned about the dual antiplatelets at the increased risk, but what about a single platelet who's on therapy?
He is the right person to answer it. Dr. Rashid or Jayendra, any one of them.
Sir, it depends on the type of stroke. Whether we are dealing with small vessel stroke, whether we are dealing with artery to artery stroke, whether we are dealing with cardioembolic stroke. So in small vessel stroke, there are lacuna stroke, there are TIAs. So TIAs, we give dual antiplatelet for 4 weeks. And lacuna stroke, we give dual antiplatelet for 3 months. Right? Artery to artery, we prefer dual antiplatelets for 3 months to 12 months. Cardioembolic stroke, when it comes to that, we don't give it. There are some studies which says that initially you give antiplatelet therapy, but followed by that we need to give anticoagulation because that is the preferred choice of treatment for cardioembolic stroke. So yes, so initially dual antiplatelet is something which we start the patient on depending on the type of stroke, and then followed by that we give single antiplatelet.
No, hypertension, the TIA, complication on it.
Of course, see,
Antiplatelets are advised lifelong.
antiplatelets are advised lifelong, but dual antiplatelet is advised for 3-4 weeks in TIs.
Single.
Yes, single. Right.
Acha, sir, one question for you.
For me?
Best time for sleep.
Yeah, please.
Best time for sleep.
Time for,
Best time for sleep.
best time for sleep. I think nights are meant to be slept.
Timing.
There is the, in that also I can tell you two things. First of all, nights are meant to sleep. You're not supposed to be awake during the night, except people like us, nocturnal. Number two, this afternoon siesta that we talk of, थोड़ा 2 घंटा सोने का दोपहर को. There was a study done by NASA. It's called the NASA nap culture. So people who have slept for more than 26 minutes during the afternoon, the association of blood pressure, hypertension, obesity is up by 17% in those people. 26 minutes. I'm very, very specific about this. My grandfather used to sleep for 2 to 3 hours, but he never had a brain stroke. But that was in last century. This century, there's an experiment done by NASA. Anything beyond 26 minutes, if you sleep during the daytime, what you call afternoon siesta, there's a good chance that you have high risk of getting hypertension, diabetes, and obesity. Does it answer my question? Your question? Does it answer your question?
I'm asking what time person should go to bed.
What time in the night?
Night.
And that's the first clear demarcation.